Okay, colleagues, I think we'll make a start. So you've had a rest, you're fully caffeinated, so hopefully raring and able to go for a great session on Sláintecare. My name is Professor Áine Carroll. I'm Professor of Healthcare Integration and Improvement at UCD. I'm also Chair of the International Foundation for Integrated Care. So as you know, the theme for this conference is taking the leap, making integrated care a reality for everyone. And this morning we had a great plenary one session where we heard from some really stellar speakers about what's happening around implementation of integrated care in Northern Ireland. And now this session is going to look at implementation of integrated care in Southern Ireland. So I'd like to pick up on a couple of the things that Rafa Bengoa made reference to. So he talked about the challenge of implementation, and in the coffee breaks and in chatting to people for the rest of the day, people have been talking about implementation challenges. So Rafa Bengoa recommended 3 key steps: strategic clarity, organisational clarity, and then building a management system for change. And then he said at a policy level that we needed to create a receptive context for adaptive change, that it needed to be actively managed, and that there needed to be leadership at all levels and also learning. So this session is going to cover a lot of those elements. We're going to break this session down into 4 sections. We're going to hear about the Sláintecare reform programme. Then we're going to hear about an innovative programme that has been implemented called the Pathfinder Service. We're then going to hear some research that has been done on that service. And then we're going to have a panel discussion with key leaders within the Irish healthcare system who are charged with implementing integrated care at scale in the South. So, the first session on the Sláintecare reform programme, our speakers are going to be Grace O'Regan from the Sláintecare Programme Management Office, followed by Muriel Farrell from the Sláintecare Programme Management Office. And I would like to hand over to Grace.
Good afternoon, everybody. I'm delighted to be here today. I am going to take you through, to explain Sláintecare in context, and for non-Irish speaking people, Sláinte means health. So Sláintecare is our health reform programme. I'm going to take you a little bit through the background as to the health service delivery in Ireland, so that you can understand the requirement for reform when Sláintecare was introduced. Going to take in context to look at some broad trends in health service delivery in Ireland and performance, and then take you through Sláintecare, the principles and what's been achieved in recent years. So Sláintecare reform is basically about providing the right care in the right place at the right time by the right team. It aims to broaden the coverage of universal care, to decentralise provision and to enhance integration of primary, community and hospital care. The reforms are complicated, the programme is broad, and reflects the healthcare system the OECD describes as complex and at times opaque. Looking back at how health service developed in the South, in the Republic of Ireland, it was different to elsewhere. If you look at other countries in the European Union from the 19th century, late 19th century, they were looking at healthy populations as an essential state investment. And from the 20th century, many European states developed universal health systems. Also, by contrast, in Britain and the United Kingdom, the 1942 Beveridge Report proposed a universal health scheme of social insurance and the National Health Service. The Department of Health in the Republic of Ireland was founded in 1947 and, inspired by the Beveridge Report, prepared a white paper, which is an outline of proposals to improve health services. However, these proposals foundered on ferocious opposition. And instead, both in terms of welfare and health policy, successive governments opted for incremental improvements. And there's various developments over the decades. So once we got to 2017, the requirement for reform is very clear. An Oireachtas committee, the Oireachtas is our parliament, on the future of healthcare, published a report making recommendations as to what needed to be done. This was called the Sláintecare report. This report was significant because it was the first time there was cross-party agreement on the long-term vision for health and social care, and the direction of health policy in Ireland was set out. The vision is to achieve universal health and social care system where everyone has equitable access to services based on need, not ability to pay. So to take you through where we have gone since the publication of this report in 2017, the Sláintecare Implementation Report, which is government policy, was published in 2018. This was a document set out the goals and the policy that would for those 3 years. What was achieved during that time was the establishment of the HSE board, government approval of the HSE health regions. I'll explain in a minute what that was about. There was a number of foundational steps taken. We see this as being kind of the initiation phase of Sláintecare. The programme for government was published in 2020, and with this there's significant amount of investment in the Sláintecare programme. Since that time, there's been a second implementation strategy and action plan, government policy published in 2021, 23, and for each year there's been an action plan that has been monitored by the Sláintecare Programme Management Office, which was set up in 2021. To broaden out just the context to explain, so you understand a bit more about health trends in Ireland, I've just pulled out a few stats that, and you can see some of them here. Ireland is among a group of 7 EU countries where life expectancy is above 82. In terms of behavioural risk factors, we follow socioeconomic gradient. In 2019, smoking was higher among individuals, the lowest income quintile. Those of the highest income quintile tend to drink more. In 21, Ireland spent 3,885 per capita in health, which is nearly equal to the EU average. And between 2019 and 2021, health expenditure per capita increased by over 12%, driven in large part by the government spending to address COVID-19. And public sources for healthcare expenditure amount to 77.4%. So just to give you a bit more of a flavour of Ireland's performance, this information comes from the OECD Government Advance. In terms of health status, Ireland is better than the OECD average on about 95% of indicators. In terms of risk, 46% of indicators. In terms of quality of care, better than the OECD average than 54%. In terms of access to care, which is a big priority in down south, we're better than the OECD average in terms of 69% of indicators. In terms of health system resources, 52% of indicators. In terms of investment, government expenditure in healthcare services increased by 34%, from 16.8 billion to 22.5 billion from the period 2018 to 2024. And if we look at acute care investment, it's increased by more than 80%, from 4.4 billion to 8.1 billion. We've also invested a lot of money in capital infrastructure. Another important consideration for the Sláintecare Reform Programme is the demographic situation in Ireland at the moment. Our population is growing significantly. From the period 2012 to 2022, the population has grown by 10%. It's also ageing, and this has implications for demands on our healthcare system. There's a lot of analysis going on at the moment. We have the Irish Government Economic Evaluation Service and other organisations looking at the data, and this informing a lot of the policy that we are undertaking. This graph shows the increasing investment in Irish healthcare from 2016 to 21. In 2017 was 15.5 billion, and in 2021 is 22.1 billion. We can see that household out-of-pocket expenses is increasing at a slower rate than government investment, and the government investment is significantly increasing. In terms of GP utilisation rates, we can see that there's different categories of access to care. So the medical card holders, 85% of medical card holders access services at least once a year in 23. 80% of GP card holders at least once a year, and 72% of private patients attend at least once a year. But interesting, when you look at the average number of visits per person, it's 5.8 for medical cards on average, 3.8 for GP card holders, and 3.1 for private patients. So I'm going to move to the Sláintecare programme itself. Now, the 2017 document that was published by the Parliamentary Committee set out 8 Sláintecare principles, and these principles have underpinned each of the implementation and action plans in the year since. I'm going to run through them quickly. Patient is paramount. Timely access to all health and social care is according to medical need. Prevention and public health. It needs to be cost effective with strong emphasis there needs to be strong emphasis in prevention and public health. It should be free or close to free at the point of delivery. The health workforce should be appropriate, accountable, flexible, well-resourced, supported and valued. Public money and interest. Public money should only be spent in the public interest for the public good. There should be engagement in order to create a modern, responsive, integrated public health system comparable to other EU countries. And it should be about building long-term public and political confidence in delivery and implementation of this plan, and it should be accountable. Another significant document that was published in 2018 was Health Service Capacity Review, and it projected demand out to 2031, and again reflecting the demographics. It set out that without reform, that the demand in services would grow by the amounts that are set out here. Daycare activity 47%, for example, nursing home places demand to increase by 39%, GP visits by 39%. So based on this research, the first 2018 government implementation strategy and action plan was developed. We see this very much as the initiation phase, and a lot of the first steps were taken, setting up the initiatives that I'll talk about more now in explain what's happened more in recent years. The 2021-23 programme, we see it very much as the foundational phase. There was two programmes. One was focused on improving safe, timely access to care and promoting health and wellbeing. There were 7 projects within that. The first project drew very much from the Health Service Capacity Review, focused on developing enhanced community care programme, developing community and primary care services, developing healthy living based on Healthy Ireland programme, and developing hospital productivity. The projects are very much set out and managed to achieve particular stated outcomes. And the Reform Programme 2 focused on addressing universal health inequalities, focusing on moving towards universal health care. So the funding for Sláintecare in Budget 21 was 2.5 billion. There's further funding available in 22-23. About 2 billion has been invested in pure Sláintecare reforms between 2020 and 2023. The Sláintecare Programme Board was set up in November of 2021. There's been 13 meetings since. It's led by the Secretary General of the Department of Health and the CEO of the Health Service Executive. And the leaders of the Department of Health and the HSE, who are responsible for delivering these projects, sit in that programme board. And then their teams report, it's regular reporting to the programme board, which reports on to the Minister and reports into the Cabinet Committee on Health. And the Department of IFIC, our Prime Minister's Department, also sits on the programme board. So I'm just going to go into a little detail on some of the programmes so you can get a sense of what has been achieved through Sláintecare to date. This is Enhanced Community Care Programme, which is a suite of strategic reform initiatives that seek to maximise impact for citizen in avoiding hospital admission through initiatives delivered within the community with service delivery reorientated towards general practice, primary care and community-based care. The focus on implementing end-to-end care pathways to support delivery of care closest to the patient and helps avoid unnecessary hospital initiatives. So based on most recent data from January to the end of March of this year, where there was 31,000 patient contacts for the programme dealing with older people, 69% of whom have clinical frailty score 5 to 7, 76% of patients were discharged home, only 6% were admitted to hospice, 6% were admitted to long-term care, and 11% of people were reviewed on the same day. And this data shows that, in this case, these teams are seeing the most complex and most frail patients urgently, and that most such cases are discharged home as opposed to going to acute hospitals. This programme is in its early days, but seen to be successful. The programme also covers the community specialist team that deals with chronic disease, and 95% of general practitioners signed up to this programme. And this figure is the number of people who've been seen to date, in February to date. And 91% of patients with chronic disease are now fully managed within the primary care setting. The GP diagnostics programme has also been very significant to date in terms of GP being able to access diagnostics directly themselves. In 2024, the progress of this programme is going to be in consolidating progress made to date. In terms of the HSE health regions, this is another very significant Sláintecare programme that is foundational to the reform programme overall. This programme is basically around 6 regions now being set up. The geographies are set out here on the map. The Health Regions Implementation Plan was approved by Government in July 23. The HSE Health Regions will have responsibility for planning and coordinating delivery of health and social care services within their defined geographic areas. The way finances are being, services are being planned and financial allocations are going to be based on population-based analysis. The HSE, which the Health Service Executive is going to be operating at a more strategic level, and it's going to be lean organisation. So there are 6 regional executive officers who have been appointed in February 24, and the health regions commenced in March 24. And there's significant progress being made this year. Another Sláintecare programme is around expanding eligibility. Various measures have been introduced since 2020 and 2022, you can see there. As a result of the measures introduced then up to last year, more than 50% of the population now are either eligible for a medical card or a GP card. Sláintecare Public Unity Consulting Contract is another significant Sláintecare project which is about removing private practice from public hospitals. It's also a core principle of Sláintecare. As you can see, the numbers are in the chart there, and the latest numbers from last Friday are now there's 2,179 consultants have signed up to the contract. The contract means that more consultant decision makers are going to be available in our hospitals out of hours and at weekends, therefore providing greater level of access to public patients. And there'll be greater, due to this significant consultant on-site presence, it's anticipated to be reduced emergency admissions, short lengths of stay, more complete care plans for discharge, and this will enable the health system to maintain more efficient and timely patient flow out of hours and at weekends, and reduce waiting times ultimately by maximising capacity in our hospitals. Another priority of the Sláintecare programme, and it's a significant political priority as well, is in dealing with our waiting lists. If you think back to between 2015 and 2021, our scheduled care waiting lists had increased by nearly 60%. In late 2021, the Minister of Health implemented a multi-annual approach to reduce hospital waiting lists and waiting times. And this approach ensures that everyone has more timely and transparent access to high-quality scheduled care. So if you look at the recent stats, there has been more people treated in our health service last year than previously. Despite a significant increase in patients added to the waiting list, overall waiting times lists have reduced each of the last 2 years. And there's been a 32% reduction in patients waiting longer than 12 months. So just a few graphs. And actually there's a number of initiatives within the waiting list action plan. Modernised care pathways, surgical hubs are a few of these. These graphs show the impact of the waiting list action plan to date in terms of outpatient waiting list trends. And this one shows day case, GI and endoscopy. In terms of workforce and capacity, this is another Sláintecare programme. The workforce since 2020, we've added more than 26,000 health workers. And at the end of December 23, the workforce is at approximately, it's over 145,000. In terms of beds, 1,222 beds and inpatient beds opened since 2020. So just to give you a quick overview, those are some of the main programmes and setting out some of the main progress being made across those programmes. But to give you just a flavour of the scope of the Sláintecare reforms and what's been achieved over the 3 years to the end of last year, you can see here we've broken down by access, eligibility, capacity and reforms and safety and quality. But just to run through some of these quickly, we mentioned healthcare, the waiting list action plan already, and in terms of unscheduled emergency care, the number of patients on trolleys, which has been an issue for us in recurring issue for us. The number of patients on trolleys in 23 is down versus 22, 22% reduction for the second half of 2023 versus the same period in 22. 22.1 million home carers were provided in 2023. There's now 174 primary care centres. In terms of eligibility and affordability, the GP care has been expanded. 500,000 more people became eligible for GP care in 2023. State-funded IVF has been rolled out. Free contraception has been extended through 23 and it's now available to all women aged 17 to 30. In terms of capacity, plans are underway to develop new elective hospitals. Once built, these hospitals, it's estimated, will facilitate almost 1 million procedures every year, which has been described as a game changer in the Irish system. The National Forensic Mental Hospital in Portrane opened in November 22. Major trauma centres opened in Cork and Dublin. In terms of capacity, there's more student places available across numerous healthcare disciplines. The workforce, we mentioned already, has increased. GP training prices have increased. In terms of reforms, we've mentioned the HSE health regions. The Health Information Bill will provide the legislative basis for the safe and secure sharing of digital health information for care and treatment. The HSE patient app will enable people to access their health information, manage their interactions with the health service, also support patients through a range of care pathways. In terms of ECC, we mentioned this already, there's 96 community healthcare networks, and there's various specialist teams for dealing with older people and chronic disease management. In terms of next steps, we're at the point now of finalising the next Sláintecare implementation strategy and action plan. We're looking at the themes of access, safety and quality, eligibility and affordability, capacity and reform. In terms of waiting lists in 24, a total of 407 million has been invested. In terms of urgent and emergency care planning, that work is being developed further, and digital funding of 91.8 million has been invested. GPS access to diagnostics has funding provided in 24 that will enable continuation of the scheme with full adult population access to the end of 24. The public-only consultant contract will ensure there are more decision makers in our hospitals, which will have an impact on the level of service that we can provide, including 7-day working. Also, in terms of reform priority 2024, e-health is a significant priority. There are challenges facing the system. As with many systems internationally, with our demographics, there's growing demand on the health and social care system. There's putting pressures on our waiting lists. It's requiring us to address inequalities in the health system. There are capacity constraints. Recruitment and retention is an issue. Hospitals are operating at maximum capacity in many cases. There's a productivity puzzle. The task force on savings and productivity has been set up. The action plan was published recently, and that's setting out a number of proactive steps to be taken to achieve savings and increase productivity. And then there's also the need to focus on capital and digital development. So that's a broad sweep of the Sláintecare programme, what it's about. The programme board, which I mentioned, and the Department HSE work closely together, and the various teams that lead on the individual Sláintecare projects. Of course, there's many people within our overall system that are working together to make Sláintecare work. And if there's any questions, I'm happy to answer those afterwards. Thank you.
Thank you very much, Grace. Great to hear the updates on the work of Sláintecare. And now swiftly passing over the baton to Muriel Farrell from Sláintecare Programme Office. Thank you very much, Muriel.
Thanks, Áine. Thank you, Áine, for the introduction, and good afternoon to everyone. I hope you're enjoying the conference. It's a great pleasure to be here and to share our experience about innovation among our frontline healthcare leaders is contributing to our approach to the integration of care in Ireland. And I was interested this morning at the first session to hear Rafa talk about the meaning of integrated care, and I had that thought yesterday myself when I was preparing these slides, so it's good to know I'm on message. And I pulled out this definition that, based on the international body of research, the Committee on the Future of Healthcare, who delivered the Sláintecare report in 2017, defined integrated care as healthcare delivered at the lowest appropriate level of complexity through a health service that is well organised and managed to enable comprehensive care pathways that patients can easily access and service providers can easily deliver. This is a service which communication and information support a positive decision-making, governance and accountability, where patients' needs come first in driving safety, quality and the coordination of care. We've heard from Grace how there is a conscious move to implementing more integrated care is being taken. In doing so, we are fundamentally supporting the move to deliver more and more services in the community settings and closer to or in patients' homes. Most importantly, we are fostering a culture of innovation among the health workforce to support the delivery of health service reform through the Sláintecare Integration Innovation Fund, which is supporting frontline healthcare workers through financial investment to test new care pathways, new technologies and new ways of working with a view to mainstreaming and scaling if successful. The Sláintecare Integration Fund is a ring-fenced, multi-annual fund allocated in the annual health budget, supporting projects with a focus on delivering the right care in the right place at the right time and by the right team. During 2020 to 2023, 46 million was committed to 143 projects through 3 rounds of funding. Initially, funding was allocated for 1 year in the first round of funding. In subsequent rounds 2 and 3, 2-year funding was allocated based on learning from round 1. The department works closely with the HSE to deliver the SIF programme, and a Sláintecare learning network has been established to enable projects to share experiences and learning from their projects and to support each other to address challenges. Strategic priorities for innovation investment in 2020 to 2023 are identified by the department and the HSE based on health policy and the programme for government priorities, and you will see these themes on the slide. Projects are supported at senior clinical and non-clinical levels to ensure that projects are tested and evaluated during and at the conclusion of the projects. Projects considered successful may be supported for mainstreaming and scaling in the subsequent budgetary estimates, subject to available funding. And just very quickly to date, SIF projects have impacted positively on health system processes, including through reductions in wait times and waiting lists for scheduled care, reductions in emergency department attendances and hospital admissions, and reductions in inpatient bed days. In terms of patient impact, there is more timely access to care, improved health status and health literacy, and improved patient experience. And just very quickly, for example, there's been through round 1 projects, there was 3,000 ED attendances were avoided, 8,000 patients were seen from waiting lists, and 15,000 people received more appropriate referrals to relevant health specialists in a community setting. The fundamental purpose of the Innovation Fund is to mainstream and scale successful projects, and we can demonstrate success in this regard. 85%, or 106, of round 1 projects were mainstreamed by the HSE through the National Service Plan in 2021, which means they now receive recurring funding annually, and many projects have been scaled. For example, 38 projects which tested integrated care pathways for people with chronic diseases and older people were mainstreamed as part of the national rollout of community specialist teams for older persons and chronic disease management through the Enhanced Community Care Programme. The online home STI testing project is now available nationally through funding allocated to Healthy Ireland. And the Pathfinder project, which tested an alternative care pathway for older people with low acuity needs, was mainstreamed in Beaumont Hospital and is in the process of being scaled to 8 other hospitals throughout the country. And you will hear shortly from my colleagues about that project. As we reflect on the programme to date, we know we have experienced that change is not a linear process, and there are challenges. Sláintecare is about working collaboratively in the co-design of the future with all stakeholders, including patients. SIF projects reflect a bottom-up approach, a term that Rafa used this morning, to implement change driven by national health policy and programme for government priorities, embraced by all stakeholders and the management of traditional barriers to change. SIF projects represent building on what works well in the system and embracing opportunities to redesign and implement elements of the care processes and pathways to improve patient care. Frontline healthcare staff are one of our greatest resources. We know we have the brightest and most highly skilled and motivated workforce, and they know, and you all know, where and how improvements can be implemented to improve patient services, and how to show leadership to create innovative ways of working. The SIF programme and projects were unique due to the strong focus on outputs and outcomes, demonstrating evidence of improvement or not, creating a learning culture and safe space to test and try new ways of working, accepting achievements and learning equally. building trust through partnership and collaborative working in co-designing improvements with patients, citizens and each other. This is essential for informing policymakers and decision makers about innovative ways of meeting citizens' needs, setting priorities and allocating resources. The CIF programme has proven to be both resilient and flexible to date. The challenges faced by healthcare staff in the delivery of these projects over the course of the programme, particularly during COVID, have been immense, and they have responded by developing new and additional ways of delivering the projects and adapting the model of care to include online and virtual options of service delivery. And in many cases, they extended the reach of the projects to a greater number of citizens. These projects demonstrate the impact of the different stakeholders coming together, bringing their knowledge, experience and views with a focus on improving the patient experience and to provide the right care in the right place at the right time. I would now like to introduce you to our colleagues from the Pathfinder service who developed and are delivering a real example of what delivering the right care in the right place at the right time by the right team with the patient at the centre looks like in action, and their ongoing commitment to improvement, quality improvement in that service. I know you will enjoy hearing from my colleagues Yvonne O'Riordan, Laura Hogan from the Pathfinder service and Professor Francis Horgan and Dr. Mary O'Neill from the RCSI. Thank you.
So, afternoon everyone, my name is Yvonne O'Riordan. I'm a clinical specialist occupational therapist on the Pathfinder Beaumont team, and I really want to thank Muriel for giving us the opportunity to share, I suppose, our journey with integrating two very, very separate organisations and placing the centre of our care firmly in the patient's home. So I suppose a case for overhaul and a reality mapping really. Why did we need to change what we were doing? And the reason is for everything that's already been discussed. In Beaumont Hospital in 2023, there was over 12,200 over 75-year-olds that attended ED. And 24% of those are 24% rise from 2018 data, with 49% of those over 75-year-olds being admitted. When you look further into the data, 49% of those between the ages of 65 and 75 were also admitted. So that's a huge cohort of frail older people who are presenting to the emergency department and are being admitted. And we know the data tells us that just because you transfer to hospital or just because you default to going to hospital doesn't mean it's the most appropriate or the safest place for you to be. We know for older people living with frailty especially, it presents an active risk, including risk of death, delirium, falls, infection, malnutrition, pressure sores, medication errors, all the lovely stuff, incontinence and functional decline leading to nursing home admission. So the case for looking at older person care and looking for alternative care pathways has never been clearer. And we know from our literature review that suggests that 78% of older people want it. If there is an alternative care option to presenting TD, that's what they wanted to happen. So initially, I suppose, everything begins with an idea, and the idea was just one occupational therapist, Paul Bernard, in his research study in 2016. So just one person had an idea, and because he had some experience in the UK about how these teams actually work. And between the initial idea and research period and meetings between Beaumont Hospital and the National Ambulance Service Director in 2017, and a lot of luck, there was some momentum gathered. Approaches were made to multiple offices for advice and signposting, and they were responded to. So those approaches to Colm Henry's office were responded to, and connections were made. And I suppose those leaders within the acute hospital settings and supporting structures, as well as within the pre-hospital setting, the National Ambulance Service, there was engagement and there was a curiosity of what could be done and what can we do differently. So there was facilitated discussions and stakeholder engagement, and that occurred for nearly 2 years. I suppose very extensive period of time before there was ever a test phase begun. And the test phase happened with the resources that were already in place. There was no additional staffing. So the ask was, let's just think differently, let's just work differently, let's see what we can do, let's see what we can learn in this phase. The process was supported by the National Ambulance Service's shift in strategic vision in 2020, where it was estimated that 25% of 999 calls could be appropriately addressed by an alternative care pathway rather than transport to emergency department, which is the traditional operation that happens. And it complements the Beaumont Hospital strategic vision of a hospital without walls. So reaching patients within their home, within the hospital, and transferring them back out to hospital again, or out to home again. Ultimately, the complementary vision still required significant planning, openness and resilience for all those initial stakeholders in the service design period. And it's worth noting that the timing is right, and it was during this initial trial that there was an invite from Sláintecare for healthcare ideas, and the application was successful. It also provided a focusing in minds from the initial service design team to say what can be done, and actually what are people looking for, what is the Department of Health looking for. And that focusing of mind gave us lots more energy, and because our application was successful, it gave us a credibility as well to continue to consider what can we do. And without this, it's worth noting that the project may not have been successful at all. It may have just ended after that first test phase. So what is Pathfinder? So Pathfinder is a novel team of the National Ambulance Service Advanced Paramedic, which Laura is, and Beaumont Hospital occupational therapist and physiotherapist, responding to low acuity 999 calls for over 65-year-olds. And it consists of both the initial rapid response team as well as the follow-up team of therapists only going out to see people at home. And it was initially piloted in Beaumont Hospital, a catchment area, Dublin North City and County in 2020, and it was scaled up to 8 other sites in 2023. Includes Tala Hospital, Carroll, Kilkenny, Cork, Kerry, Galway, Limerick, Waterford, and Letterkenny. So very different HSE hospitals, voluntary hospitals, rural, urban, so different settings. So how did we get to this point? I suppose the conditions were right to test a new way of working, to work differently, to work in a collaborative way. And the service sits really nicely between the patient's home, the acute hospital and community services. And that's what pre-hospital is. Everybody shared the same aim of providing the best evidence-based care to patients we meet, providing the best version of therapy, of assessment that we can do in the patient's own home, and to listening to what patients want. And it's very important, I suppose, that the trust was built and there was an understanding, and all those little successes along the way, such as getting the Sláintecare funding, just gave us that extra bit of credibility and energy and a focusing of the minds for us to continue. So I'm going to hand you over to Laura, who's going to highlight some of the role that research has played in embedding the collaboration even further.
Thank you. Thanks, Yvonne. Saying that it hasn't always been plain sailing, research has been a significant driver for navigating that initial power struggle of two organisations coming together for the first time, and an inevitable part of new team alliances forming. This team's research has been cemented in service evaluation, embracing a quality improvement ethos and a pragmatic research approach. It's been spearheaded by a need to understand, does the model work? Is it what older people want? And are we doing what we think we are doing? So in 2021, this is the results of the initial paper, a retrospective cohort study of the Pathfinder service was conducted over 5 months, investigating the impact of the service on ED conveyance rates and patient safety. 178 patients were responded to by the Pathfinder's rapid response team over an initial study period. The average age of the patients was 79.6 years, and the average clinical frailty score was 5.5. 64% of these patients remained at home following initial Pathfinder review. None represented to the ED within 24 hours. 10% represented within 7 days. The majority, 67% of patients, required follow-up by the Pathfinder follow-up team and/or community-based services. Feedback demonstrated that 99% patient satisfaction with the service. A key finding being that older people with a high level of frailty or a diagnosis of dementia are no more likely to be conveyed to hospital or to represent to ED following a non-conveyance, proving that this was a partnership that worked. A subsequent qualitative study was also undertaken to evaluate the patient perspectives of the model using thematic analysis of open-ended responses from 429 telephone interviews. 5 primary themes were identified: the professionalism of the interdisciplinary clinical team, the right service in the right place at the right time, the role of Pathfinder in getting the ball rolling, following up and connecting through coordinating referrals and services, the lasting impact of the experience on the patient and their next of kin, and the value of skilled communication with the older person and across the team. The clinical team was involved in completing these 429 patient satisfaction surveys. This patient feedback proved to be hugely important in navigating the everyday challenges about how the service should work. It took 2 vastly different organisations out of it and led to greater appreciation of what mattered to the patient and what they required. A very useful tool when it comes to resolving conflict. And as you can see here are some of the examples of the quotes that we received. It is what people want. Older people deteriorate psychologically in hospital. Excellent. I would give it 10 out of 10. I think it's brilliant. It's better than people sitting in A&E. And the fact it links back with the community, brilliant. It should be everywhere in the country. It makes so much more sense. We now realise Mum didn't need to go to hospital. And a continuation of our results from our annual review in 2023. Again, 611 older people were assessed by the Pathfinder Rapid Response Team. 62% of these older people remained at home rather than being conveyed to the emergency department following a 999 call. Again, the average age was 82 years and average clinical frailty score was 6, being moderately frail. Over 80% of the non-conveyed patients required the Pathfinder follow-up team over subsequent days. 96% of the non-transported patients remained at home at 24 hours. 87% remained at home by day 7. This data shows that Pathfinder outcomes remain consistent and positive. Thank you very much.
Thank you very much, Yvonne and Laura. So now we're going to hear a bit more about the research that was done. So I'd like to invite Professor Frances Horgan and Dr. Mary O'Neill to the podium, please.
Good afternoon, everyone. My name is Mary O'Neill, and my colleague, Professor Frances Horgan, and I conducted an evaluation of the Pathfinder service, and this is a summary of our findings. So the Pathfinder service, just a little bit of background from our point of view when we were coming in to evaluate. Pathfinder is a collaborative project between the National Ambulance Service and Beaumont Hospital, OT, occupational therapy, and the physiotherapy department. It serves the Dublin area of Beaumont, the Beaumont catchment area, which is one of our largest hospitals on that side of the city. Pathfinder is dispatched by the National Emergency Operations Centre, known as NEOC, and responds to low acuity emergency calls for people aged 65 years and over. And it serves the Beaumont catchment area. So the partnership also includes Dublin Fire Brigade because they provide some of the emergency responses in the Greater Dublin area as well. Now, NEOC, when a call is received, they identify that this is a Pathfinder call. So a call can come in for Pathfinder from 3 sources: directly in to NEOC, the referral, and a crew can refer in, or Dublin Fire Brigade can refer a call to the Pathfinder service. And just a little reminder, the service includes the Pathfinder Rapid Response Team, includes an advanced paramedic, an occupational therapist or a physiotherapist. And the follow-up team will include either an occupational therapist or a physiotherapist. Now, our findings show that the Pathfinder service model is a safe alternative to an ED admission and to conveying an older person to hospital. Almost 2/3 of the EMS calls, the emergency medical calls, attended patients who were not conveyed to the emergency department when they had a Pathfinder review. And feedback obtained through the various evaluations shows that this is a service that older people and their families like and want. So the Pathfinder service model represents inter-organisational working between Beaumont Hospital, the National Ambulance Service and Dublin Fire Brigade, and they serve that catchment area served by Beaumont Hospital. The picture on my right, there, that is the model of care for the National Ambulance Service. And what you can see then is that the bringing together of the different organisations as we talk about the model here. So my colleague, Professor Horgan, and I were tasked with evaluating the service. So we set out to explore the feedback of the team who deliver the Pathfinder service to give insights into the impact of the Pathfinder service model from a team and a service delivery perspective, to enable understanding of the aspects of care, team working and the future expansion of the service. We conducted a qualitative study, and ethical approval for that study was obtained from our own institution, RCSI. We conducted 19 semi-structured interviews. Qualitative data was collected between January and February 2023. And each of the interviews were recorded, transcribed, and then they were returned to the participants to member check them before the analysis was completed. So we analysed and transcribed the data from the compiled data, and we extracted 6 main themes and a variety of sub-themes. So our first theme was focused on establishing the Pathfinder service model, and considerable investment went into this by the teams at all levels. They established a vision for the service. There was clear leadership at all levels, strategic right through to clinical leadership. It was a patient-centred service. There was a clear focus on patient safety, team working and risk management, positive risk management. And the data showed and acknowledged that these were different organisations coming together. And the team members worked differently. And in some of the services, the frontline staff were engaged on a daily basis in their normal roles of leadership, change, reporting and measuring outcomes. So they drove the service. And the second thing was the leadership at all levels. And this was very important. It was about getting the right people doing the right work and driving, not just clinically, but strategically as well. The second theme focused on enabling older people to live at home. And the team at all levels were very committed to enabling people who were safe to leave at home to stay at home. And they were fully aware of the impact of long delays in emergency departments for older people. So they focused on patient safety. Now you had on the visits, the Pathfinder visits, highly skilled and competent staff conducting the home visits. And they conducted comprehensive home assessments when they were there, and they looked at models of integrating care based on their assessment. So there was clinical leadership was a key component to this service. But in addition to that, supported by the management teams at all levels, they developed a standard operating procedure manual so that when they were in the home of the individual, they had to make a joint decision that they were happy for this person to stay at home safely or to convey them to hospital. And they had their standard operation procedures to fall back on in the event of they having maybe a slightly different view of the next step. Each could advocate, they could discuss with the family, but they had to make that joint decision. So bearing in mind that they're very competent staff that were there, and the therapist would have come from a background in Beaumont Hospital where they had a long-established frailty programme, and they were very familiar with working with this age group in the emergency department. The next theme that was extracted from the data was around governance frameworks and processes. So this was very important, and about patient safety was key, and it was also about learning. So there was a lot of work involved here, and this demonstrated the inter-organisational working and collaboration. So there was a Pathfinder Management Forum, which had a complete overview of the delivery of the service right through to frontline. So there was a strategic leadership there. It was also funded, a project that was funded by Sláintecare, and there was a commitment to delivering this service and enhancing the care of older people who were safe to live and be cared for at home. And there was that commitment and personal experience by members of the team as well. They were familiar with the needs of people, and they were also familiar with the length of stay older people can experience in a busy emergency department. It required change management. It required a cultural shift to bring the organisations together and a paradigm shift. So it required the development of structures and processes to facilitate that and to enable the service to be delivered safely. And part of that was about developing the manual for the frontline clinicians who are out on the calls, and that was agreed by all the organisations, that it was something, there was a shared agreement on the use of that document, and that it would act as a guide for the staff on the calls. So another theme that came up in the data was about training and support. Now, each organisation had their own background, their own training, and one participant talked about their organisation having very good policies, which they were proud of, but they did say every older person couldn't be conveyed to hospital, and that the frontline clinicians out on the visits had to be confident in the decisions that they were making when they made a decision that somebody was safe to keep at home. So they talked about training and support to facilitate the development of the teams, and they talked about team building, advanced practice, frameworks of competence to guide their work, developing standard assessment tools. They talked about the importance of opportunities for continuing professional development for each, in each of the organisations, and they talked about the importance of having a mentor and having a support system and opportunities for reflective practice where they could bring maybe situations to the table and discuss them and learn from them. The participants also had a vision for the future of the Pathfinder service, and they talked about the national rollout of the Pathfinder service. Now, that was outside our brief, but they all had ideas about how the service could be developed, and Yvonne mentioned there that it has expanded to other sites around the country. But they talked about integrating Pathfinder in with community services, and the data showed very clearly that the Pathfinder team members and the clinicians out on the calls invested heavily in collaborations with GPs, community services, and so on. But they talked about the importance of developing referral processes and pathways of care so that the comprehensive assessment conducted in the home travelled with the patient and was there if the patient presented or at some other point to the hospital or to the Pathfinder service. They talked about the importance of having a good understanding of the care of older people and of frailty and the need for frailty education. They talked about the rollout of the community paramedic and where Pathfinder might fit in there. And they talked then about the expansion of the service based on local needs. So Pathfinder was described in the data as a people intervention delivered by people. And they talked about having the right mix of clinicians, personalities and attitudes. They also talked about having a very competent and capable team out there as well. So it's an example of a collaboration between primary and secondary care. And our sixth and final overarching theme was around research and sustainability. And Yvonne mentioned the publications that were prepared by the team to showcase the work that they completed on the Pathfinder service and also to reflect the views of the people who received the service. So they relied heavily on the patient feedback and the stories, which were very important because the service started around the time that COVID happened. So it was very important for older people because the Pathfinder team visited many older people at a time when few others may have been calling to their homes. They talked about enabling participation, being important, expanding the service. They talked about having robust audit and research and evaluation built into the Pathfinder activity. And they wanted the service to be informed by the data, driven by what the feedback and the audits and evaluations that would be conducted. But they did highlight the importance of onward referral to enable the work completed by the Pathfinder clinicians out on the visits. They talked about the importance of that onward referral for older people and to adapt then to local needs. So it's definitely a new way of working, but it brought the organisations together and it showed what Pathfinder could do. They were very, very focused on patient-centred care, patient safety and enabling patients to live at home safely as long as they could. And the final slide is just a snapshot of the work of the team, of their research work and publications to showcase the work to date on the Pathfinder service. Thank you very much. I'll hand over to Francis.
Good afternoon, everyone. So I suppose reflecting on the learning of Pathfinder, and as you can see, there's been quite a considerable amount of evaluation, from the service evaluation to looking at the patient feedback, and it's overwhelmingly very positive, to presenting some case studies, and then we came along to talk to the key stakeholders. But I think there are wider lessons for integrated care that can emerge from a very successful pathway that is Pathfinder, and we can see some of these mentioned here. I mean, communication from the very outset was critical, at management level, at the frontline level, and between the two organisations. So I think that's a key lesson in terms of that communication and successful collaboration. We could see two organisations coming together, and certainly, there can be cultural differences in organisations. So again, building trust between organisations, and there were certainly champions. This came through very clearly. And I think for any new and innovative services, we need to have champions and leaders that are going to drive that change, and then all the motivating factors, like was alluded to by Yvonne, in terms of the investment in the pilot study and the testing of the programme, and the and the funding that came then as an endorsement of doing the right thing. Partnership and trust was critical, both at a management level and right down to the frontline level. We had senior clinicians, clinical specialists, physiotherapists and occupational therapists in the home, going out in the emergency vehicle with the advanced paramedic, working in their clinical hub. I suppose leaving the safety of their organisation, of the hospital and the physiotherapy department, and going out to a clinical hub in the environment, in a small clinical room, and then taking those calls and getting on the road to see that older person in their home. So again, a lot of partnership and trust in terms of those decisions that needed to be made in the home, and then having that mentorship. So again, support for individuals who are delivering innovative care, integrated care. Each of the clinicians had their mentors in their own organisation, so they had that support, and as we've alluded to in the slides, there was a lot of learning. Everything doesn't go right, and there's a lot of learning from these situations. So that managing relationships both at the very high level on the management forum in terms of the operational governance, and then managing those relationships right down to the very front line of being in the person's home and making that joint decision making is critical to integrated care as well. It's obviously important to share the learning as well and to share the success and to learn. And now we see that Pathfinder is rolled out to 8 other sites. So again, I think the lessons from integrated care are that shared learning and innovative practice. I suppose, geography can differ, populations can differ, the service configuration can differ in the different organisations. So I think we have to reflect on maybe the tweaks that we might need to make. But the overarching sort of structures that guided the Pathfinder team in terms of the SOPs and the governance, having those ground rules there to refer back to gives a lot of security in terms of rolling out the service and implementing the service. So here's just a snapshot of those principles. Again, that principle of partnership and trust and champions and vision. And central to this vision in Pathfinder and for all integrated services is the patient and the patient voice. And I suppose in some of the sessions this morning, we're hearing about workforce and about co-design and the voice of the patient, because ultimately this integrated services are for patients. And in the case of Pathfinder, it was about not conveying the person to home and keeping them safe in their home and reassuring them and their family. So again, we're bridging gaps between hospital services and community services and primary care. We're looking at those structures that we need for these services to work. Critical, and certainly something I reflected on in the interviews, was the experience that each of the team members came with from their own individual organisation. So reflecting that expertise and that long-standing experience that many of the clinicians had working in Beaumont Hospital, coming up through the services, the acute services, being on the ward, working in rehabilitation, working in the emergency department, seeing the frailty intervention team. So they had long-standing experience of care pathways, and they wanted to kind of go beyond that. So I think we mustn't forget the workforce and the experienced clinicians, and that's been alluded to throughout the sessions today as well. The patient feedback and the stories, highly motivating, the positive feedback and the testimonials of the service as well, and the safe feeling that individuals have when they're receiving excellent services. We have to evaluate what we're doing, we have to measure what we're doing, so it has been a very exciting collaboration with the Pathfinder team in terms of evaluating, and of course we need to embed research in everything that we're doing as well and build the evidence to policy to practice, which again has been alluded to in themes in the programme today. So again, this picture here shows the complexity of what is Pathfinder, and I suppose any integrated service is going to be complex because it's going to be delivering the right care at the right place at the right time, but it's also the right people in the right place at the right time. And Muriel alluded to, right care, right place, right time, and right team. So we're building on this complexity all the time. We can see from the very start the piloting, the testing the idea, and then the investment came, and then it went from strength to strength. And we can see now that rollout in the wider teams as well. But over to the right-hand side of the slide here in the grey is that ongoing evaluation and learning, and a forum for learning and sharing as well, as we're all doing at this excellent conference. So I suppose in terms of these general principles, and again there are a lot of frameworks in terms of systems theories and frameworks for us to evaluate all our work. But I suppose emerging from the work that Mary and I did and reflecting on this session today were some key messages that came through for us in terms of the wider learning for integrated care, and that is leadership and champions in those organisations, from the very top right down to the very bottom. That shared vision and values, keeping the patient at the centre, having the guidelines and having the processes and the governance structures there as well. Thinking about the patient and their family as the partners in their care. And there was an excellent session this morning on family carers and the role of the family carer. And I suppose, population change and how care is going to have to change and be innovative with limited resources going into the future. It's very much about team building as well, and the different members of the team, and working well together and building trust, and maybe coming from different organisations, and allowing time for that team building process as well, when we're maybe coming from different areas and we're coming to work together, because part of this is obviously change management also. We have to have the tools to do our work as well. So I suppose something that Mary and I did a little ride along in the vehicle and went to somebody's home and could see how having access to the records was able to expedite the management of the person that we were called out to see. So again, just that integration system, integrated records, so they could kind of see that the person, where the person was last seen in the clinic and what the management was. Learning is very important. Obviously, we all make mistakes, and change management is all about sharing and learning. And I suppose, there can be conflict in change management. So again, we have to have that shared vision to drive the energy to deliver innovative care. So again, I suppose not underestimating the collaboration that we had and all the learning that Mary and I had as well from this opportunity. So again, just an excellent opportunity to collaborate with colleagues in Beaumont, but thinking of the wider lessons for integrated care as well. Thank you very much.
Thank you very much, Whoops. That any better? Yeah. So thank you very much. That was really interesting to hear about the project itself and then the research that you've done on it. We're a little bit behind time, so if I may, I'm going to just ask a couple of questions of the clinicians and then a couple of questions of the researchers, if that's okay. So my first question for Yvonne or Laura is, from a clinical team's perspective, are there any practical considerations that aided the embedding of an integrated way of working? Will come on.
Hello?
There we go.
Okay. Yeah, it's the simple to the more complicated. And, Francis and Mary have talked about it, but things about just even being co-located, being able to share an office space, getting to know how other organisation works through your colleague. Because we would never meet, an occupational therapist and a physiotherapist will never be in a paramedic world. Before this, we never met each other, really. So this is, like, historically, there was no bad blood or good blood between us, which is a good and bad thing. But the fact that we were able to co-locate in a location, and that location was in a primary care hub as well. So it wasn't aligned with Beaumont Hospital or with the National Ambulance Service. That was highly advantageous for us because we got to know each other, we got to form as a team. And the other thing is that that opened doors because we were welcomed into Beaumont, and you could see us on a ward in the emergency department in a day hospital, but you could also see us out in a local ambulance crew in the back of an ambulance. So it opened that doors so that we could seamlessly travel from one area to another and build those relationships and build that understanding. And from the very get-go, when you have no understanding, you have to learn that and you have to be open to asking those questions. And the other thing is the governance structures that Mary and Francis have spoken about. Because we had those, clinical huddles every morning, because we had our monthly meetings with, key stakeholders and managers there, that we were accountable. And we had to prepare, and we had to be, we were accountable to our patients every day, but we had to be accountable to organisations too. And I think that was really powerful.
Thank you very much. And what has been the greatest driver for that collaboration, do you think?
It's just on. So obviously it's all patient-centred. So if it's right for the patient, then we need to continue doing it. And as the survey has showed, and the ladies have attributed to it as well, that 99% patient satisfaction is amazing. And obviously underpinning that with robust evidence-based research, keep us going and make sure that we are doing the right thing for the patient at all times.
Great, thank you very much. And just to say, colleagues, that there are a number of sessions on evaluation on Wednesday, so keep an eye out for those. So thank you so much. So just then picking up nicely on from a research point of view, you mentioned, I think it was Mary, I'm not sure, maybe it was Francis, the importance of having a mentor and reflective practice. So how did that work?
This was pointed out in the data that the value of having a mentor was very valuable because this was a new service. It started from scratch. Yeah. And there's different support structures in different organisations. So this was what the data showed would be nice for teams that would be developing, that would be a nice learning opportunity for them. Because as Laura and Yvonne said, the therapists don't normally visit the home from a hospital base. So they have to get to know each other. They have to get to know the workload that each of them encounter. So there may be, that was something that came out in the data actually, that the advanced paramedics were very caring towards their therapy colleagues because they knew they were working in a different domain. And it showed that. So the reflection gives an opportunity for either to debrief and just to identify the learning, because there's bound to be new experiences as each enters the other's territory, shall we say, or area of work.
Great, thanks. And then Francis, you mentioned that enablers for success include partnership, trust, and managing relationships. So what did the data tell you about how the team managed that?
Yeah, I guess it was very evident from the very beginning that they built a team, and that team continued right throughout. So I suppose if there was any troubleshooting or any difficulties, the team could come together both formally and informally at all the different levels. So right up to the management forum, right down to on the ground delivering the service. So I think they were open to developing solutions and working collaboratively together. And, you know, there was just a great openness there to coming together to actually solve it. Yeah.
That's wonderful. I wish we had longer for this panel, but I'm afraid we don't. Colleagues, thank you so much. It's been really great to hear about the work in the Sláintecare office, the work of Pathfinder, and also the research into the Pathfinder project. Colleagues, please put your hands together for the panel. Thank you. So we're going to move on to the senior leadership and its importance in implementation of integrated care. So I would like to invite up on stage my three colleagues from the Health Service Executive. We have Dr. Colm Henry, who is the Chief Clinical Officer within the Health Service Executive in Ireland, Dr. Siobhan Ní-Bhríon, the National Clinical Lead for Integrated Care within the Health Service Executive, and Mr. Tony Canavan, who's a brand new Regional Executive Officer in one of the new regions in the West and Northwest in our Health Service Executive. So welcome, colleagues. Come and sit down, make yourselves comfortable. Over the different sessions that we've had today, implementation, governance, leadership are just these words that keep coming up. And this session is about implementation in our health system. So there's a lot of opportunities, Tony, with the new health regions, and one of the audience asked a question about why do we have 6 health regions in Ireland? So I thought I would ask you that question first.
What was the question?
Why do we have 6 healthcare regions in Ireland?
Well, I suppose...
Or please share the reason for regionalisation into 6 regions. That's exactly it. Thanks for the question, Clive.
That's better. I suppose, first of all, I think when I look at the rationale or the logic for the regions, it's about, I suppose, bringing decision making, bringing the delivery of care as close as we possibly can, to where patients experience that care. So I think, dividing the country into regions and making each region operationally responsible for the delivery of care in that patch, I think is really important. It also allows then for staff to own what they're doing and to really take kind of pride in that. And I think that connection then between the staff working in the health services and the people receiving the care, that becomes stronger. And I think we saw a little bit of that during COVID. And I think the potential for us achieving that again through this new regional structure is important. We have a lot of work to do to get there. We're still a national organisation. I think you described me as brand new. I'm not sure that the old grey head suggested I'm brand new, but so I've been around for a while, but the regions are brand new, and we've got a lot of work to do to implement them. There's practical things like we have to put a management team in place now to cover each of the regions. At the moment, it's just myself, so that has to be done between now and the middle of September. And then we have to have other layers of management underneath that. And it's not all about management, but you do have to have structure and you do have to have governance so that people understand what's going on or what's supporting the delivery of care overall. And then once we've that done, and I would expect to have most of that done by the end of September, certainly by well into October, then we can get back to focusing on the delivery of care again.
Yeah, thanks. And just I think that Grace covered it, but the new healthcare regions in Ireland cover health and social care. So they'll be responsible for all the health and social care services, or the vast majority of them in each of the regions. Thanks, Clive. One of the other things that have come up, Siobhan, and was mentioned specifically by the previous panel, was senior clinical leadership. So how important do you see senior clinical leadership in these types of undertakings?
I personally think it's hugely important, and what we heard just here today from Pathfinder, our clinicians taking leadership, recognising what the difficulty was, and putting an innovative path in place in Pathfinder to do that. And I think clinical leadership is something that happens at every level of the organisation. It can happen when, you know, you're in a role like myself and are fortunate enough to have oversight of a number of clinical programmes and support them through developing national approaches to care, national standards to care. But senior clinical leadership is most of all actually about the team on the ground and people acting really up to the top of their licence. And I suppose just to say here, I think we've been doing that quite well in Ireland with the progression of advanced healthcare, of advanced nurse practitioners, and now policy with the Department of Health for the development of advanced practice in health and social care professionals. So I guess, Áine, what I'd say is senior clinical leadership comes in at every stage in the delivery of healthcare, be it at national, regional, or very local level.
And there's going to be a new chief social worker appointed, I believe was announced in that last week. So that's a very welcome development. I think that shows a real commitment to a multidisciplinary approach to the work that we do. A question from the audience, and Colin, I'll put this one to you. How do those working in the HSE sustain innovative practice aligned to Sláintecare when recruitment is frozen and development posts have been annexed?
With difficulty. That said, we've undergone. Why have we got to this place where there's an embargo at the moment, which will be lifted in time? We've recruited an extraordinary additional number of people over a very short period of time. So after years of perhaps stagnation in recruitment, and you'll be familiar with those from your time there, there's suddenly a rapid expansion, 25,000 more people employed since 2019. And we found, if truth be told, that we couldn't recruit against the numbers we were funded for. And that leads to its own difficulties. So eventually that embargo will, of course, come to an end at some stage. But what we have to do at this point in time, part of our response is making the most of what we have at the moment. And what we saw in a report that came out from the Department of Health last week was, despite the extraordinary expansion in resourcing in healthcare over the past 10 years, the productivity that you'd expect corresponding to that hasn't been as great, certainly in numerical terms. What has added is the depth and quality of care. There's more subspecialists, there's more community care. Look at the extraordinary investment in Ireland in the past 5 years in these IFIC centres, in these chronic disease centres. It has been extraordinary from a very, very rapid journey where we're dependent on acute hospitals and almost inviting people to be lured by the gravitational pull of acute hospitals, to now creating centres, 26 out of 30 for chronic disease and ICPOP. So I was intrigued by some of those earlier presentations. You can see where there's a reform at speed happening, but there was a huge catch-up required, and that was front-ended by a huge amount of recruitment, which we weren't able to keep pace with. But that embargo will come to an end. Just to go back to the regional point, if I could, Áine, it's an important question as to why we have it. Ireland is a small country, but it's a very noisy one. And the regions, like all politics, all healthcare is local. So when you're looking at CELTA, for example, and how Letterkenny, Sligo services are integrated with local services, so that people get the kind of seamless care they expect, that's best organised in a local way. And we know from some of the presentations that led to the kind of governance model we're looking at over the past year that people expressed huge frustration that they were delivering chronic disease teams had multiple points of governance to different reporting lines. It's impossible to operate a team that is in any way cohesive in that way when you're trying to address patient needs.
Thank you very much. And if I might go back to the 3 key steps that Rafa Bengoa suggested this morning, which was strategic clarity, organisational clarity, and building a management system for change. I'm just going to ask each of the panel to comment on how are we doing from those 3 key steps from an Irish point of view.
I think, in some ways, I think we're at the very early stages, and I do always remind myself that we're trying to do this as well in the context that we continue to deliver services all the time. You know, I remind myself that there were 23 babies born in the last 24 hours in across the CELTA group, and there were thousands of people attending the emergency departments. There are as many people in the community receiving support through our mental health services and so on. So what we're trying to do is a very significant structure and strategic change while we're continuing to deliver the best care we can to those 23 babies that were born today, if you know what I mean, and everybody else that receives care. So it's complicated. And we're trying to do it with the same people, you know, so the people that we're asking to change, we're doing it in that context. I think one of the things that I picked up on really strongly in the presentation earlier on about Pathfinder was the importance of relationships. And again, if I refer to my own patch, I can see the importance of that. One of the areas that we developed Pathfinder in was Letterkenny, and we've lots of problems in Letterkenny. We've lots of good things in Letterkenny as well, but lots of problems associated with access to care. And what Pathfinder also helped us to do was it helped us to develop the relationships both between the people working in the hospital and outside of the hospital. And they've had other spin-off benefits as well, and have helped us to develop the services there. So if you could think about that on a broader scale then across all of our hospital services, all of our community services, and trying to develop the relationships that we have and that we saw developing through Pathfinder, that's really a key important strategic step for us to take now going forward.
And relationships is something that just keeps coming up time and time again in all the literature and the evidence that is being produced around the world, the importance of attending to relationships. So I'd agree with you. Siobhan, what are your thoughts on the 3 key steps?
Well, I think we have actually quite a considerable amount of strategic clarity in having a national healthcare policy that's very clearly focused on bringing care closer to home and making the interfaces between care as seamless as possible. And that sounds so easy, but I think what Tony has said indicates how difficult it is. And again, the Pathfinder presentation gives a very clear understanding of, even if you're introducing that amount of change, the structures, the processes, the relationships, the people that need to be in place to do it are substantial. So I would say we have quite a considerable amount of strategic clarity at a national level and indeed regionally. It's putting the management structures and the organisational structures in place to do that probably. That is the biggest challenge. And I think that's at different levels in different parts of the country, in fairness, and moving that shift then from acute, that sort of division between acute and community, to breaking down those walls and having people's care managed seamlessly between the two is a massive organisational change. And I suppose just to put in one of my own thoughts on this, and certainly learnings over the last few years, we have to mind that process, and we have to mind the people who are doing it, and that's why change management is so important. So we can set all the strategies we want, but unless we manage that change carefully and learn from it and evaluate it, I think that really is our organisational challenge.
Yeah. Thanks, Siobhan. What are your thoughts, Colin?
I think as the strategy is very clear, and that came across in our Department of Health colleagues. There's a very clear strategy for healthcare in Ireland. It's not a perfect document, Sláintecare, but people can paste onto it what they understand it means. So we don't need to do it again. It's very clear, and it's something against which we're, as we heard from another presentation, that we can easily give. We can easily match when we're bidding for estimates, when we're looking for funding, and so on. The problem is, as with any change, that's the strategy and that's the direction. It's the culture bit and what comes next, and getting people to, and then the enablers. Yeah. And if you look at, I'm lucky to live in Cork for the past 20 years, not native there, but I'm lucky. And it's a straight motorway from Cork to Dublin. It's 2.5 hour drive, within legal limits. I think it's 2.5 hours. Probably 2 hours for you, Tony, I'd say. But it's a straight drive. But I remember when they were building it, there was, initially before it was built, when I first came, there was 16 towns you went through. And then it became 12, then 10, then 8. But the only bit that people ever saw as the motorway developed was the bottleneck. Yeah. So it was defined continuously, not by the great stretches of road, by the bottleneck in Fermoy, which was one of the last to give way, and the other bottlenecks. And so it is with integrated care. We keep talking about the seamless care, that somebody who has chronic illness or somebody with genetic illness who's seamlessly provided care right across hospitals. But the enablers that provide that there's bottlenecks there. The single patient unit identifier, electronic healthcare record that's accessible at every point in real time in the journey, the diagnostics and so on. And we've heard today and earlier from all the investments that have been put in these areas, and these are bypasses of some bottlenecks, but there's still bottlenecks there.
Yeah, absolutely. We have a couple of questions from the audience. How do you see primary care taking its place in integrated care models being developed in Ireland, and what is being done as part of Sláintecare to make this happen?
I'll get started. I'm sure Tony has loads of thoughts on that. So primary care really is sort of the foundation stone of integrated care, isn't it? Because everything goes back to primary care, and most people's journey to healthcare starts in primary care. So how do we manage that in a system where our GPs are providers in their own right? Well, we've got GP leads now involved in the community and health networks and in the regions, and I think supporting our general practitioners to work as part of our teams is absolutely key. And I guess at national level, we've had huge support from our clinical advisor, David Hanlon, who's been probably the person who gets asked to do the most amount of pathway involvement, to do the most amount of work in making sure that those journeys for patients work right back to general practice. So they're just some initial thoughts. Jodie.
Yeah, I was going to say that for sure, that one of the things I'm really looking forward to is having that more structured engagement with GPs. I think is probably a really important way to put it. I was in Ballyshannon last week and I met with a group of GPs that were working there. One of the things that they were reflecting back to me was that they're enthusiastic about their now involvement in a chronic disease management program, and they see that as being something that they would have always had an interest in, and now they feel supported in doing that, and they feel that they're part of a team that's delivering in that as well. So I think both of those are really important. I think it's about bringing GPs maybe in a more structured way into working with the health services, and maybe combining the efforts of both the primary care team that's working for the HSE and general practice in a more effective way. So I think there's a lot of potential there for sure.
Yeah, any thoughts, Colin?
Yes, I do. I'm going to rob some figures that Mike O'Connor's out there gave me. We have, last year, we had 166,000 people attended local injury units. It's a lot of people. And we had 1.5 million people came to our emergency departments. It's a lot. How many people attended GPs? How many consultations? Mike, you're not allowed to answer. It's 30 million. So that's where the great bulk of healthcare interactions takes place, in primary care. Now, what's worked well has been in chronic disease, the GP contract, and a great acknowledgement to Orla O'Reilly for work behind that, for Pat Healy and others for implementing it. And we see now that 92% of people with chronic disease are managed solely by their GPs. We see a fall in admissions with chronic disease to Irish healthcare since 2019 of about 16%. What hasn't worked so well is the bit of unscheduled care. And that's in Limerick Hospital, a much troubled hospital, staff under huge pressure. Over 50% of people who come directly to the emergency department have not seen their GP. And that may be because of, I'm not getting into GPs, it may be because they haven't been able to access.
Yes.
So I think in terms of going back to that we're reforming while we're at the same time trying to deliver care, as Tony says, and to do so with an ageing population of chronic disease, the one bit that we're really getting somewhere with the chronic disease. I think the challenge we have is the unscheduled care is multiplying the points of access in a way that's credible for patients, that they feel they don't have to come and wait in a trolley for 12 or 24 hours.
Yeah, okay, thank you. Oh, sorry, yes, Siobhan.
Just to add to that, sorry, just to say, National Service Planning last year, which was particularly challenging, but the one area that I think all of us were so keen to push was the increase in the number of GP trainees, and that's gone up to 96 this year, right? Gone up by 96, not to 96, and that increase is going to continue over time. So that is a key foundation to increasing our GP numbers, particularly as a certain percentage of our GPs are over 55 and will be retiring in the next 10 years.
Yeah. Do you want to say something else? No. Okay, one of the other points that Rafa Bengo was making was around creating a receptive context for adaptive change. And I'm just thinking about flying the plane while you're trying to build it, which seems to be what you're saying. So how do we build the plane while we're flying it? How do we create those conditions for adaptive change?
Yeah, this might sound a bit strange, but I'm not so much worried about how we deliver care, because I know what we're doing in the hospitals. I know what's happening in the community, in my patch, and I'm confident that we're on top of that, and we've got good people there that are making sure that we're delivering the best care that we can day by day. So, but what is a bit more challenging then is maybe managing the context outside of the region. So the political context is really important. So if this coming Maybank holiday weekend, for example, the numbers of patients on trolleys awaiting admission in our emergency departments, if that was just to shoot up, of course there would be a political reaction to that we would have to respond to. So managing that response and managing how we deal with that response and how we can keep the political system well informed about what we're doing and why we're doing it and what we're trying to achieve and how we're managing, I think that's going to be a real challenge for sure. The other part of that context, though, is more internal, and it's about, I think it's about trying to develop a shared appreciation of what we're trying to do. So, of course, there's the local political system that has to be part of that, but also I think just local service users as well have to be part of that. You know, what are we trying to achieve together? What kind of health service do they want? What would success look like when we're finished rolling out Sláintecare, if we want to describe it like that? But I think even trying to work on that together to have a clearer shared understanding of what that would look like, I think is really important. That's part of the context, I think.
Yeah. I've got an alerts thing stuck on my phone, and there is another question, but so apologies if I've got the question wrong, but there was a question in the audience around the national pathways that they're doing in Wales, and are there any plans to do something similar in Ireland?
We have developed some modernised care pathways, and this came up from the design where Siobhan has our national clinical programme. So what we've done is we went back to clinicians and said, is there anything else we can do other than add someone to a wait list for a consultant? I don't know if this corresponds with Wales. We have now 28 of those in 84 sites. In urology, we have pathways for the most common referred conditions, that's lower urinary tract symptoms, incontinence, hematuria, where we often have ANPs managing these out in the community under a single governance. They're very Sláintecare friendly. Many are implemented. We have virtual fracture clinics where 40–50% of patients, after being seen in a virtual way, are sent, aren't forwarded on to a consultant appointment. So, yeah, multiple different pathways, moving away from this traditional model of having to see a consultant, only one healthcare professional, in only one setting, in a setting which isn't really fit for purpose for something which requires multiple points of access across different sites and in the community.
Thank you. Did that answer the question? Must have done. Okay. Thank you very much. And if you please ask questions again, my phone seems to be working again, so thank you. We've mentioned change management a few times. I always think that's a bit of an oxymoron, that you can manage change, you can't. You can try, but you can't. But yet, we know, in inverted commas, that there needs to be a systematic approach to how we effect change within these complex health and care systems. How do you think we best do that? Maybe start with you, Siobhan, since you've got
I'm going to mention some of our colleagues here in the audience from the Chronic Disease Management Programme, and indeed people from the Integrated Care Programme for older people. They've taken quite a systematic approach to supporting change. Very simple things like laying out what different team members do and supporting teams to meet, how to structure their meetings, how to understand the roles and functions of members within the team, and then to support that with clinical guidance and pathways. So I don't think change like that happens by accident. It does take that degree of management support and work, and I do think it needs to be minded. And then I guess, I've said this before, but I'd say it again, as we find new ways of working, it's critically important to monitor and evaluate those to understand what we're doing and what we're getting right, and also what we need to improve on. So I do see it very much as a process, but one that if it's not minded, is not going to work out. We do need to do it and do it carefully, I feel anyway.
Yeah. Tony, what do you think?
Yeah, well, it's just one aspect of it, and it's kind of, it's almost boring, but actually the bit that I'm focused on at the moment is about communication with staff. I'm conscious that there's a lot of change coming in a very short period of time. Yeah. And so I'm really focused on trying to make sure that as much as possible that we keep the lines of communication open, that we're telling people openly about what's happening, what to expect, and answering questions when they're being put to us. And I think we'll be in that mode probably till the end of September or thereabouts, and maybe for a while after.
Yeah, and communication is another word that is coming up time and time again in the posters and the presentations. The importance of both listening and communication are really key. Colm, any thoughts on change management?
Yeah, I've been involved in a few of them, and they're never easy, but by the time you get involved with them, there has to be a clear acceptance that change is needed, that burning platform argument. You have to acknowledge that people are going to be afraid about their jobs and roles, and there's no point in glossing over that. Yes. And so that has to be acknowledged. But that said, you have to refocus people while acknowledging that and dealing with it. You have to keep drawing people back to why you're changing, that while their positions and their roles are important, you're trying to build a better service that's more attuned to patients' needs. But most of all, I think with any of these change things is to avoid, no matter what what instincts either you have or other people have, is to avoid being drawn into cynicism, because cynicism, in its worst manifestation, will damage and halt any change. There's so many optimistic people. Anne Lawler is here, for example, but there's so many optimistic people out there who have every reason to not to be optimistic.
Yeah.
More and patience most of all. So you must lean into that, because, as I say, while cynicism at a superficial level can be fun, when you're trying to effect change around people's lives, around services that matter to people, there's really should be no room for it.
Absolutely. There is a view, though, in healthcare literature that if you tip too far the other way, you tip into toxic positivity. So there's a sweet spot somewhere in the middle, I think. So not being too cynical, but not being too positive. We have to be, I think, realistic. Positively realistic, maybe that's a thing. And I would just like to give a little plug to the Health Services Change Guide. If we're talking about change management, it's a fantastic tool and loads of resources available for, it's freely available for anyone that wants to have a look at it, but in particular for HSE staff. So the final question I'm going to ask the panel before we head for our lovely reception is around leadership and learning. So that has come up both in the plenary session this morning, but also in what the researchers in the Pathfinder and also the Sláintecare Programme Management Office have said. So leadership and learning, is that oil and water, or can those two things really work well together?
If I might start to say, any leader who thinks they know it all is in trouble. So any sort of leadership to me is about learning. You have to keep learning and keep learning on the job. Be prepared to change and listen to what people are saying around you and learn from the information, the experiences that are coming back. So I think you can't have one without the other. And as I said earlier, to me, leadership is about people working to the top of their license and being supported to do so. And again, to do that, it requires an awful lot of learning. That's my own feeling on it.
Thanks, Siobhan. Tony.
Yeah, the leadership piece for me on the hospital side is about trying to get people to turn around and face outwards and look out at the community and know that it's okay to to work in that way and to engage in that way. And similarly on the community side to face each other and say it's okay to integrate and to work between primary care and social care, and similarly in with the hospital. So that's the leadership piece that I'm trying to work on. The learning piece is very straightforward for me. At a time like this when we're changing a lot and we're trying to implement new ways of working, we're going to make mistakes. We absolutely have to be open to admitting that we're going to make mistakes, and therefore we're going to learn from them as well. So the two things really do go hand in hand for me.
Thank you very much, Tony. Colin.
Just briefly, I had the good fortune to meet Anthony Fauci last. I think we were at the same thing.
He was very busy last week.
He was very busy, yeah, but he really came across as somebody who had obviously so much knowledge, was so expert, had done so much, but also what came across was a kind of humility and an acknowledgement of mistakes, but not in such a way as sometimes you find among people here, where it rattles their confidence and they collapse. And I suppose that's what defines resilience, is not just picking pieces up after things go wrong, but actually owning it then and moving on. And the way he described quite movingly, I thought, his work as a clinician and researcher during the early days of HIV when there was no treatment, through to the treatment and to where we are now, and then to his work in Africa, was a model of resilience, of somebody who faced a nihilistic scenario of people dying everywhere of an incurable disease, to then driving research that led to its effective treatment, and then bringing that treatment to sub-Saharan Africa, and then persuading a US president to invest 16 billion and save 25 million lives. That's
it was
extraordinary. For all of us.
It was extraordinary. Yeah. And I think what's really struck me as well was his adaptability. So he would be on a particular career path, and then HIV was emerging as an issue, and he completely pivoted to all his attention on HIV. So coming back to that adaptability, I think, is a key lesson. And likewise, colleagues, I wish we had another half an hour, if not an hour, to chat more, but we don't, because we've got a reception to go to. So colleagues in the audience, I would like you to put your hands together and thank our panel, Dr. Colm Henry, Dr. Siobhan Ní Bhraoin and Tony Canavan. And I would like to thank you all very much for your participation in this Sláintecare session. I think you have seen the transition from policy right the way through to practice and then plans for the next phase of healthcare change in Ireland. It has been a very great pleasure for me to chair this session. Thank you very much to all the contributors. My thanks to you and all the questions that you asked. I hope you've had a fabulous first day, and I hope you will go home, rest, reflect, and come back bright and early tomorrow morning, and we'll have another fantastic day tomorrow. Have a wonderful evening. Take care.